Welcome to Oncology Data Advisor. My name is Rahul Banerjee. I'm Assistant Professor of Medicine at the Fred Hutchinson Cancer Center in Seattle. September is Blood Cancer Awareness Month, and as a result, we're doing several episodes this month around multiple myeloma. And today, it's my honor to speak with Dr. Gurbakhash Kaur about dosing of medications in myeloma, twice weekly, biweekly, or somewhere in between. Dr. Kaur is an assistant professor of medicine at the University of Texas Southwestern Medical Center in Dallas. She specializes in multiple myeloma and AL amyloidosis. Dr. Kaur, Gurbaksh, it's a pleasure to host you today.
Thank you for having me, Rahul.
Some of these things are topics that are near and dear to both of us. So, let's jump right into it. So, the title is said twice weekly versus biweekly. I always get confused. Apparently, biweekly is every other week. Twice weekly is twice per week. It can be once weekly. Let's talk about all of those or more with bortezomib. How do you dose bortezomib during induction in your practice, and how does this differ from how maybe some of the trials were done?
Well, historically, the trials were mostly done in the 1, 4, 8, 11, so twice a week dosing, right? That's how the trials have been done. But in our clinical practice, we deviate from this, and it's for several reasons. So I dose Velcade on a weekly basis whenever I do induction. But even in the relapse refractory settings, if I end up using a Velcade-based regimen, I prefer to keep Velcade only once a week. This is to make it patient-friendly, number one, because myeloma is a chronic disease, and they spend a lot of time with us, and they don't need to be seeing us twice a week if they really don't need to be seeing us twice a week. So I factor
Agreed.
that's a big motivation for me, actually. And the second is the side effects, and particularly peripheral neuropathy. The rates are as high as 30% when you do twice a week. So I feel that why put somebody, when somebody's living for 10 years, and their myeloma is under control, but then it's the chronic debilitating neuropathy that's impacting their quality of life. I think there's an onus on us as providers to take responsibility and to be more mindful of how we schedule and give these drugs.
Absolutely so. Because I think it's important to remember, and I've seen this, you've probably seen this even more, right? That some of these patients have neuropathy for years afterwards, even when they're on lenalidomide, like Revlimid maintenance thereafter. And it's like that bortezomib, the neuropathy can really, as you said, be quite debilitating to them. And so it makes sense for us to kind of de-escalate as we can. And does that change whether someone's transplant eligible or transplant ineligible, or for everybody wants weekly bortezomib?
Well, if somebody's transplant ineligible, then I prefer to use the Maya regimen, daratumumab plus
Hmm.
Revlimid plus dexamethasone.
Myself as
If
well.
somebody is transplant eligible, I tend to use a quadruplet: daratumumab, Revlimid, Velcade, and dexamethasone in all comers, irrespective of their high risk status or not. So that is my preference, and I still do once a week Velcade.
Likewise, that's exactly what I do for both transplant eligible and ineligible. This is very helpful. So then let's move, stay on the topic of bortezomib and now switch to the other side. Let's say someone did undergo transplant. Do you ever use bortezomib for maintenance, either because of refractoriness, or I should rephrase, len intolerance, or because I have high-risk cytogenetics? And if so, when you dose Velcade in this setting, how do you dose Velcade in terms of dosing and frequency?
I very infrequently use Velcade maintenance, partially because many patients end up having peripheral neuropathy, even with once a week
Hmm.
dosing. It's
Hmm.
mild, it might be grade 1, but I do not want them to progress to grade 2. So keeping that in mind, I use it particularly in 414. I can use a second generation PI such as carfilzomib, and I tend to not do a weekly regimen, and not every week. I still do, say, once a week, but I might do it every 2 weeks, just as sort of as a maintenance protocol.
Very helpful. Yeah, so now we're going from twice weekly to bi-weekly in this setting, and by every 2 weeks, and I agree. And so it's worth noting to the audience listening to this to think, I think, you correct me if I'm wrong, Gurbaksh, kind of the Emory group kind of first presented some of this like doublet maintenance, like V plus R maintenance, and they had once weekly Velcade. I practiced very similar to you, that I space it out to every other week, and similarly for carfilzomib, Kyprolis, I'd do the same. Um, so let's talk about Kyprolis. This is actually very, each topic's kind of going from one by one to the next topic. So for carfilzomib, Now, let's say someone does have relapse disease after they've been on LEN maintenance, and let's say you're considering, DARA KD or ISA KD. How do you dose carfilzomib for your patients and why?
So, Rahul, before I even go into this, I think that this topic is very near and dear to your and my heart is because, historically we had a disease that really didn't have good treatment options. So I think the trials, and it's always easy to be a Monday morning quarterback and reflect back and say, hey, this approach is wrong. That is essentially not the case over here. I think endeavors have been done by our colleagues who moved these therapies into clinical practice.
Hmm.
And back then we didn't have good options. We didn't have a bispecific or a CAR T waiting. So you wanted to get the biggest bang for your buck, and that may have driven why scheduling practices were the way they were recommended. And now we are in a different era, and we need to adapt. So from
I love
going
that.
from that into how I dose carfilzomib. I still prefer to, and with carfilzomib, the dosing is everywhere. First of all, when it comes to the grams, is it 30, 20, 36 or 36, 36? Day 1 and 2, 8, 9, 15, 16. Is it 27 milligram per meter squared on day, every day? Or is it 56 milligram per meter squared once a week, 56 milligram per meter squared 2 days a week, to even 70 milligram per meter squared once a week. So we have such degree of variability in the doses of it, in how frequently we give it. And we don't have a unified approach, and
Agreed.
that is what it is right now. So I tend to, like I said, I do value quality of life, and I like my patients to spend as much time away from my office and my practice as they can. So,
Absolutely.
without compromising their efficacy, right? So generally, the first dose is 20 milligram per meter squared on day 1. And subsequently, I will transition into a 56 milligram per meter squared on the second week and the third week. So it's a weekly dosing, but I don't do twice a week dosing here as well. And part of that is, obviously quality of life and time away from the doctor's office. And the second is this fear of, many patients are weary of having the cardiac toxicity profile that comes with carfilzomib, and such as it could be simple as chest pain to shortness of breath to actually having systolic dysfunction. And we know that it's higher when the doses are higher, actually.
Agreed.
So I tend to not utilize the 70 milligram per meter squared unless I really need to. Somebody who's young, has very high risk disease, and has an explosive relapse. I think those are the settings where I do go for that. That's not to say I rule it out completely. But generally my go-to regimen is 56 milligram per meter squared on a weekly basis.
And on a once weekly basis. This is very elegant commentary. A couple of things you said, I'll just to draw attention to. I hadn't thought of it that way. Yeah, you're right that there was a time when KRD or Dara KD more recently, that was kind of destination therapy for many of these patients, and there it makes sense to kind of hit the max tolerated dose of carfilzomib you can. We have better options in later relapses for sure. And you're right, that heart failure risk, the hypertension risk, the heart failure more than the hypertension, obviously, it scares patients, especially some of our older patients who have some more comorbidities at baseline. And you're right, all those studies that show this carfilzomib heart failure signal were typically 56 per meter squared twice weekly. Doesn't mean it doesn't happen at once weekly, but I agree with you. I think the dose really makes a difference. How much IV fluids makes a difference, and so forth. So this is very, very helpful. Um, do you ever use 70 milligrams once per meter, 70 mgs per meter squared once per week, the way the Arrow trial tried to do, or you do 56 once per meter squared?
I have used 70 in a very, in the patient, like I said, the patient who desperately needs it, the one who has very explosive disease and high risk, and I need to get really, really good responses. I think those are the patients I tend to reserve that for. Maybe for my older patients, I don't go for the 70 milligram per meter squared. My younger patients, I do, in the right context.
Absolutely. Makes sense. Right. This context makes a big difference on how we approach our patients. So, before we talked about these PIs, so bortezomib and carfilzomib in the setting of, we didn't have more advanced options, and now we do have advanced options. So CAR T and bispecifics come to mind. So bispecifics are fascinating because I know you just said how carfilzomib dosing is all over the place. I would say bispecific dosing is also all over the place, mainly in terms of frequency. And as you know, we're filming this interview in September. 15th, 2023. We now have three bispecific antibodies that are approved: teclistamab, talquetamab, elranatamab. Let's talk about teclistamab because that's the one that I think you and I, but you have the most experience with here as a BCMA targeting bispecific antibody. Um, how do you dose teclistamab? Not so much the step-up dosing period, but let's forget about cycle 1. From cycle 2 onwards, how do you dose teclistamab? How would you like to dose teclistamab? What makes you change the frequency of dosing? How do you approach that for your patients?
So, I think we're at an interesting juncture when it comes to bispecific therapy. We're finally at a point where our decisions to whether somebody gets teclistamab or CAR T is not really driven by availability, but more so by patient preference and what their biological needs are in
Agreed.
terms of disease, right? So my first preference is to go to CAR T for patients who I think are candidates for it, and then bispecific therapy is a second option because, again, like I said, the theme of my practice is time away from the doctor. So you can enjoy your time away from my office and don't have to come there on a weekly basis. But that's not everybody is going to get CAR T because of myriad of reasons that have been highlighted in every publication or podcast online. So in that cases, we have to be practical, and bispecific therapy becomes a very good option, a very response, a treatment that has really, really good response. We do our step up very differently. We don't do the full, we don't follow, we do it, I believe, 1, 3, and 5, and our patients are out by 7th day. Just because hospital beds are always in crunch, and so we try to squeeze as much time out of that as we can. Up until this point, the majority of my patients who needed teclistamab are the ones who needed it once a week. As in, I didn't have the liberty to go to every 2-week option or every 4-week option because their disease responded. They responded and they actually relapsed off, and I had to go to something else. And these were patients who were on the waiting list for CAR T and all that once it got approved. Now we're going into a phase where I think that's going to change. And I think we have very little data that we can space out dosing, right? That's just the reality of it. What would I like to have happen? I think we need to have a response-driven approach when it comes to bispecifics, and that's partially driven because how good they are, the cost of how much they cost, and as well as the significant side effects that they carry. Infections not being understated, right? So I would love an approach, and I might tailor my practice towards that if they achieve a stringent CR or they achieve an MRD negative response after a certain amount of time, I may stop, or I may change the frequency of the bispecific. That's sort of how I foresee myself going into the in the coming months when it comes to the bispecific, and when it comes to teclistamab.
Agreed. This is very, very helpful. And I think what you're getting at is kind of a response-driven paradigm more than a time-driven paradigm. Obviously, a little bit of a mix of both, but I think you're right. Many of us in myeloma were used to all right, 6 months of this, 6 months of this. If you achieve this at 6 months, then do this. And what you're getting at absolutely makes sense. That benefit risk ratio, the benefit of this drug at weekly dosing versus the risks in terms of infections. We were talking about CMV reactivation, weird viral things. That kind of shifts over time. If someone's already in a CR, that benefit risk is now going more towards the risk with weekly dosing. So this makes sense. I guess maybe I'll go back to wrap things up. Kind of one of the themes you brought up kind of throughout this whole podcast is the idea of kind of like time toxicity or just the amount of time that people are stuck spending in clinic, whether it be for twice weekly Velcade, which you avoid for that reason, twice weekly carfilzomib, or once weekly teclistamab. Are there other strategies or things that you think can help with time toxicity, or how do you spread the awareness to others in the community to start implementing this and not having patients come in so often to clinic?
I think we can think all we want and we can have theories all we want, but we need to produce the data to change minds, to say, hey, this approach is equally effective if you do it this way, and still you will get the efficacy that you want, because all of us are well-intentioned and we don't want to compromise our patients' care and the response that they're going to get from a therapy. So, one of the things that you and I are doing is, with our real world project, we're doing the Flatiron real world database analysis. We've looked at patients who've gotten Velcade based regimens in terms of induction, and we've evaluated, well, how often did they get once weekly? How often did they get, or more, not even how often, but what are the patterns of prescribing Velcade in the community, in the academic centers, and then compare the efficacy, assess the side effect profile when it comes to peripheral neuropathy, and sort of make a case for it. I think that sort of evidence needs to be out there, because it is not sexy in today's day and world to do a study that's just going to say, hey, once weekly Velcade versus twice weekly Velcade. That's just not going to get funded. There's
Agree.
bigger questions to ask from a funding perspective, but I think the questions you and I are asking in this project will answer that, and will make a case for it. So I think we need to generate data to convince minds that this approach is okay and this approach is perfectly fine to pursue, and that's how we're gonna, make change.
I love that. Very prescient words of wisdom there. Yes, for anyone who's listening, not anyone, lots of you who are listening to this podcast or reading it, stay tuned. And Dr. Kaur and I are working on some ideas around this to change some hearts and minds in favor of once weekly proteasome inhibitor dosing in terms of response or toxicity guided de escalation of bispecific antibody dosing and so forth. So stay tuned. Uh, Gurbaksh, this has been awesome. I actually learned a lot, even though we've already worked together on a bunch of projects together already. So thanks again for your time. I really appreciate it.
Thank you so much, Rahul. As always, you're wonderful, and thank you for having me.
Of course, and to all our readers, again, thanks again for listening in or tuning in or reading into this. And this has been another episode of Oncology Data Advisor. Thank you all. Have a good day.